Welcome to Save Your Thyroid, a podcast all about thyroid nodules. My name is Jennifer Holcomb, and I advocate for fellow patients suffering with this very common condition. Thyroid nodules impact 70% of adults in their lifetime, and the standard of care is surgical removal of half or all of the gland. But in recent years, safe and effective non-surgical treatment options have become available. In this podcast, I sit down with patients and physicians to discuss life with thyroid nodules, treatment options, and how to save the thyroid whenever possible. Welcome, everyone. I am so excited to have you join us for today's webinar. I would like to introduce today's special guest, Dr. Jules Aljammal. He is a board-certified endocrinologist who has been treating patients with thyroid disorders for more than a decade. He runs a successful medical practice in Salt Lake City, Utah, and has treated over 2,000 patients with malignant and non-malignant thyroid nodules using cutting-edge technologies. Dr. Aljammal has published on his clinical experience using radiofrequency ablation and has been an invited speaker at national and international scientific meetings. He has also shared his expertise on radiofrequency ablation by providing specialized hands-on training to over 20 practicing endocrinologists and interventional radiologists around the country. Thanks so much for joining us today, Dr. Aljammal.
Good morning, and thank you for having me today.
I would just like to welcome all of you who are joining us today from the Save Your Thyroid community and the general public. Tell us a little about yourself, your background, your medical training, and why you decided to become an endocrinologist.
So I'm originally from Syria. I moved to the US and did my medical training and fellowship training in endocrinology at the University of Pittsburgh Medical Center. Why I became an endocrinologist with focus on thyroid disorder, my internal desire to help people, me witnessing firsthand, my mom was a teacher, witnessing firsthand the fulfillment you get from helping other people achieve their potential and the joy you get from that. And then working with the world expert in the field of genetic testing of thyroid nodule, all those combined together, I think led to me becoming the physician who I am. And I think part of that is the reason why I created the North American Society of Interventional Endocrinologists, working with other colleagues to make sure awareness about thermal ablation technique is shared with all patients and other physicians, and even helping other physicians to get the experience and the skill to be able to provide their patient with this treatment.
You're doing great things with the NASWI organization, and I would just like to say I really enjoyed the webinar you guys hosted a few days ago. I think it's really wonderful that you're educating physicians about RFA and all of its different applications. So now tell us a little about your practice, the Thyroid Clinic Utah. What is special and unique about this practice?
So our practice is really focused on thyroid disorder and thyroid patient. By doing that, we have this availability for our patient. It's harder to see an endocrinologist, and it's also harder to see a thyroid specialist. And by focusing on that, we give our patient the access and the availability to be able to guide them in the nuance that can happen when you have a thyroid nodule or you have a thyroid disorder and you want a good advice about how to manage, how to improve. We offer a genetic testing for nodule that are indeterminate, imaging study with ultrasound, radiofrequency ablation for treatment of benign nodule, and other tools that help patients to achieve their health.
I appreciate you mentioning the thyroid focus of your practice, and I'm sure many of our viewers can identify with the difficulty of getting in to see an endocrinologist who is a general endocrinologist because they're having to wait sometimes 6 months to see that provider. And so having your focus be on just thyroid is very good for those patients to be able to see their physician in a more timely manner. For anyone who is unfamiliar, let's talk about specifically thyroid RFA, who it is for, and how it's performed. Kind of give us a general overview.
So radiofrequency ablation, the concept of it, what we are doing, we're using an antenna that delivers electrical current. And the point of the electrical current on the tip of the antenna is to cause the ions, which is kind of electrolyte and other things that inside the cell, to vibrate. This friction that happens with the back and forth of motion of those ions cause the tissue to boil. And we do know cells die immediately if you hit a 60 Celsius degrees. So you're trying to bring the temperature high enough that lead immediately to the cell death. Well, that's the concept of thermal ablation. Now, we currently use it in benign thyroid nodules. We have studies are done currently in the US for treatment of microscopic thyroid cancer or cancer even smaller than 2 centimeter. And we use it in other part of the field outside of thyroid disorder. But in thyroid, mainly we use it for treatment of benign nodules, and we treat also, as I mentioned, microscopic cancer. In thyroid cancer, we have this treatment where we target lymph node in the neck when a surgical intervention become not a choice for the patient, when patient have already multiple surgeries on their neck. Standard of care is surgery for metastatic disease to lymph node. But after multiple surgeries on the neck, it becomes sometimes harder to be able to eradicate those lymph nodes without causing more scarring and more damage to the organs. So radiofrequency ablation become a tool in that situation.
Absolutely. And how many RFA cases have you done to date? Have you had many patients who've come from out of town to see you for this procedure?
It's interesting you're asking. So we have up till now, we already crossed 500 patients with treatment with thermal ablation. Yesterday we had 5 patients. 2 of them were from Salt Lake City, from Utah. 2 of them were from California, and 1 came from Nevada. So we do have people seek us from around the world. We have patients from Canada, from Pakistan. We have patients internationally come and fly to do this procedure.
Describe for us then how you typically perform RFA in your practice, and tell us about maybe some recent cases that you've performed.
Let's talk about yesterday. Yesterday we have I had 5 cases. 4 of them were my patient. 1 of them were my colleague, Dr. Ahmad. We worked together on this procedure in the office. But my patient, we had a patient who had a toxic nodule. It's less than 12 cc. Uptake and scan confirmed that this nodule is toxic. The patient been symptomatic, having struggle with palpitation, symptoms of hyperthyroidism, insomnia, fatigue. And the patient has been reluctant about considering surgery for many years. So they see this approach as a choice of treatment. And our data show that if you have a toxic nodule less than 12 cc in volume, you have a chance of 90 to almost 95%. With 1 session, you can get normalization of thyroid function test. The patient have already treated up till now. We've been monitoring for almost now 5 years. After you achieve normalization, most of those patients stay normal. To date, I did not have any case of recurrence of hyperthyroidism after achieving normalization.
That's
now,
great.
That doesn't mean it's not going to happen, but to date, I do not have any recurrence of this. The other patient we have treated were more compressive thyroid nodule, goitrous thyroid nodule causing symptoms of dysphagia, difficulty swallowing, difficulty breathing. Some of them struggle with sleep apnea, and they have brachial deviation contributing to problem like that. And treatment with thermal ablation, we do know it will shrink those nodules in 80 to 85% of the time, more than 30% to up in some patients. You can see 90 to 95% volume reduction. And those patients generally will feel better in 2 weeks to 3 weeks. That's kind of the type of patient we have treated in the last session yesterday.
That's exciting. And yeah, I can speak from my own experience that having a very large compressive thyroid nodule to shrink 90% in my own experience has been tremendously beneficial for my own symptom relief. I can relate to those patients. Tell us some about your clinical research. We said earlier that you've done some writing on this topic.
Yeah, so we have published already in the Journal of Endocrine Society our data about outcome and safety of thermal ablation in benign nodule. We already published our data for treatment of malignant lymph node to the neck and outcome, and that was also published in the Journal of Endocrine Society. And we're currently working on multiple studies and multiple papers, including an outcome, retrospective outcome of treatment of patient with indeterminate nodule with negative genetic testing, looking at a multi-center study with colleagues from around the state of what are the predictive factors for success for treatment of thermal ablation. This is the largest study we have right now. We have closer to 250 patients, and we're trying to evaluate what could be the factor to indicate this is going to be a good nodule to be treated. What is interesting, because it's retrospective, it does not really give you the full answer, but it can point out what could correlate with this. And what we have noticed, which is interesting, that the amount of time you spend on thermal ablation is associated with a higher success rate. In my personal opinion, that's most likely a result of of a couple of factors. Number one is the attention of the physician who's doing the procedure for completeness, much as they can. And that comes with experience. So I think the more time you spend on treating the nodule is a reflection of that more than anything else.
Very good. Okay. Well, I know everyone is anxious to have you answer their questions. The first question is about a very small 3.5. This patient says 3.5 millimeter, but I think they probably mean 3.5 centimeter thyroid nodule. What tests should they have before pursuing RFA?
So generally, you're right. Most likely 3.5 millimeter is a nodule, may not be associated with symptom to drive the need for doing additional testing or even treatment. Current American Thyroid Association guidelines recommend really against biopsying that nodule that does not look suspicious less than 1 centimeter. 3.5 centimeter, when we're dealing with a benign nodule that's causing compressive symptoms, you start your workup really by looking at the nodule itself. So your evaluation with imaging study should give you an idea about how suspicious the nodule is. So based on the ADA guidelines, and there's other method of evaluation of thyroid nodule, you can estimate the risk of cancer in that nodule based on the way it looks. We have something we call spongiform nodule. Spongiform nodule is a nodule when you look at the ultrasound, it looks like a sponge in the inside. And those nodules have a chances of malignancy less than 1%. So if you have a nodule like that, which is larger than 2 centimeter, one fine needle aspiration may be sufficient to say it has a very low suspicious characteristic, benign cytology. One biopsy for me is enough for deciding the next step of treatment. If it's causing dysphagia, difficulty swallowing, change of voice, having difficulty breathing, to go and do the treatment. Some nodules do not have that characteristic. Some nodules have a risk of cancer of 10 to 15%. You may do one benign cytology, and you're trying to confirm this is a low likelihood of malignancy. The whole point of doing repeated biopsy is really trying to say, I attempted multiple times to prove it's cancer, and I cannot prove it is cancer. And because I could not prove it's cancer, I feel comfortable to proceed knowing that I may still miss stuff. And you can still miss stuff even with repeated biopsy. Some studies show that the risk of malignancy, even with 2 benign cytology, is 2%. But we need to caution about that. It all depends on what's the pre-probability of cancer based on imaging study. Because the ATA guidelines say virtually the risk of cancer, if you have 2 benign cytology, virtually the risk of cancer is 0. That is based again on the pre-probability. The same thing the ATA also say, if you have a suspicious thyroid nodule that have a risk of 70 to 90% on ultrasound for malignancy, do not trust 1 benign cytology. You may have missed something. This is important to keep in the back of our mind when we evaluate, but that's kind of the basic. That's for benign nodule. If you're dealing with toxic nodule, we already know toxic nodule have a lower probability for malignancy. So 1 benign cytology usually is sufficient in those situations, but you want to complete your workup and make sure you're not missing other medical condition in the background, like coexistence of grave disease. I had a couple of patients have what it looked like a toxic nodule, but the further workup confirmed grave disease. They didn't have any other nodules. And then the uptake and scan indicated diffuse uptake compatible with Graves. Those are not going to be a good candidate for thermal ablation.
Right.
Versus a toxic nodule, you do not have grave disease. You do have a single nodule that is overworking on uptake and scan. Then you are going to have a better success in achieving your goal, which is normalizing their function after treatment.
So just to kind of overview that, for these patients with benign thyroid nodules, they're going to need 1 to 2 biopsies. Biopsies would come after the ultrasound. And then for the hot or toxic nodules, they're going to need an uptake scan also to show that it's just the nodule that's producing hormones and not the entire gland that's overproducing.
You want to confirm I'm targeting the source of the problem.
Right.
If you're going to just ablate because you can ablate, that may not fix the issue that the patient is coming from.
Exactly.
Now, you may have a situation where maybe it's a little bit different approach. Some patient may have just very large nodule causing compressive symptoms, but they are managing their hyperthyroidism with medication. They do not want to proceed with surgical intervention, and they want the nodule to shrink. So that's a different kind of concept there. And it will be dependent on the scenario. Every patient is different. Every patient treatment is different and should be individualized based on their need and what's the concern they have.
The next question is about regrowth. Is it possible that a nodule can regrow after it's been ablated?
Yeah, that is possible. And it's estimated in studies around 5 to 10%. But let me go back to this important thing that sometimes we miss. So if we look at thyroid nodule in general, without any thermal ablation, when we monitor those nodules, most of them, they stay stable. but it's around closer to 11%, 10%, to up to 20% of those nodules will regrow. And when you look at the studies of thermal ablation, you can see 5 to 15% of those nodules will regrow. So what this tells us basically, the more thorough the ablation, the more complete the ablation, the more we do not leave any residual tissue, the higher the chances we're not going to see a regrowth. But the nature of the nodule plays a role. You can leave some tissue, and if this nodule is one of those that doesn't tend to grow, you may not see any regrowth. And this is a concept that is important to keep in the back of our mind. It's a combination of internal factor related to the nodule itself, its capability to grow, its capability to continue to replicate and expand, versus and add to the skill of the physician. The more the full and complete the ablation is, the higher the success. But that also need to be balanced, a skill of the physician with avoiding also complication. We do not want to overtreat and cause more problem. We're trying to shrink nodule, we're trying to control symptoms, we're trying to help people breathe better, eat better, not have a problem more because we are aggressive and cause more issues than the benefit. With thermal ablation being that safe with very low complication rate, some patient of mine argue, I'm happy with the way I feel, with the volume I achieve, as long as it's stable, and I may consider this in the next 10, 15 years in my life. I do not feel a problem with that. So again, we're trying to do no harm, provide better, and make people feel better.
The next question is non-surgical treatment a possibility for children? This person is asking about a 17-year-old who has a suspected papillary thyroid carcinoma.
I'm going to split this question, kind of try to answer it in two different ways. Thermal ablation is safe in someone who is 17-year-old. I think it is safe in someone who's 17-year-old. You can do thermal ablation as long as you are following the same standard, making sure you're not having any complication. Yes. Now, when we talk about papillary thyroid cancer is a little bit different in concept or other thyroid cancer, follicular or anaplastic. They are different when we're trying to treat benign. So when we are treating thyroid cancer, our goal and the concept when you are treating is to completely eliminate. It's not to leave 5%, 10%, or 20% cancer in your neck. So when we are trying to treat, the job is I need to make sure I do not see anything left of this. That's what we do surgery. We are trying to completely to eliminate, remove the cancer. Because if we leave cancer in the neck, theoretically there's increased chance of the cancer spreading. Theoretically, there's increased chance of the cancer changing over time and become more aggressive. So in that concept, that does not sound the correct medical treatment for long term. Now you can play it different ways. You can say someone maybe 85-year-old may not really worry too much about what's going on in the next 5, 20, 30 years versus someone who's 17-year-old, who they have their full life to be able to see the outcome, the complication. From that concept, we need to be cautious about choosing the right patient for this type of medical treatment. And we do know in general, that doesn't mean this is the situation for the patient. When we see thyroid cancer emerge early, we know that they're going to behave a little bit more aggressive. And because they may behave a little bit more aggressive, that may not be the right option for someone who's 17-year-old to consider. Now, in the future, the studies or research may show this statement may not be valid, and it will be. But until those studies are done, we are going to be guessing, and we're going to base our guessing based on the available data.
I would just like to add to that too. I think for many people, they don't realize the importance of treating thyroid cancer with thermal ablation within the context of how large the tumor is. So if you would mention the size threshold that's important for treating thyroid cancer.
So that's a very important question. So if we look at the studies that have been published around the world, and the current research now is being done in the US. So let's take that. So radiofrequency ablation, the studies from South Korea, was for tumor between 0.5 to 1 centimeter. And they needed to confirm there was no evidence of metastatic disease to lymph node. They wanted to confirm there is no evidence of aggressive behavior of the tumor on biopsy. They wanted to make sure it's not sitting on the tracheal wall, looking like invading. It's not sitting close to the capsule where you cannot really completely ablate it without destroying surrounding tissue. There's things that need to be evaluated to choose the right person for that. Currently in the US, we have 3 centers doing clinical trial for treatment of primary papillary thyroid cancer. Mayo Clinic, Johns Hopkins, Memorial Sloan Kettering, and their criteria is almost the same. The only difference, they're using a little bit different sizes. One of them uses a size less than 12 millimeter, one is 15 millimeter, and the last one was 2 centimeters.
Oh, wow.
So all of them less than 2 centimeters. And the concept is simple. Every time we're trying to treat cancer, we're trying to completely eliminate. When we're doing an ablation, just to kind of to simplify it for people, think about a pen, and the tip of the pen is the area where the ablation happened. That ablation area is like a small grape. So when you're treating an orange and you're trying to put a grape into it, you need to really do that multiple times to be able to achieve the whole thing, but you're still going to have corners where you may not be able to ablate. When we choose patient for papillary thyroid cancer treatment, we try to make sure they're away from the capsule. We try to make sure that I have an antenna that is 5 millimeter, the tumor is 5 millimeter. The area of the ablation will completely surround the tumor and expand a little bit beyond, destroying it completely. But when you reach those sizes where the tumor is so large, pushing on the capsule, you do not have any more safe zone.
Right.
You do not have the capability to completely ablate this, and then you are leaving cancer in the neck. And that will not be a good option of medical treatment. Again, do no harm. Provide patient with the right treatment, not just half treatment.
Yeah, so just to kind of summarize that, I kind of like to think about it like I have a small grape inside of my hand. The grape is the cancer and my hand is the healthy thyroid tissue. And you're going to put that probe inside and burn that grape, but you're also going to burn a little bit around the outside of that grape into a little bit of the healthy thyroid tissue. So if that grape is, like you said, an orange, there's not going to be enough healthy thyroid tissue there.
Choosing the right patient is very, very important.
Yes.
To get a good outcome, you need to choose the right patient.
Absolutely. Absolutely.
Or you're going to end up with result that is not going to be satisfactory, and you may end up with a result that push back on advancement of thermal ablation and thyroid disease, because you're going to get bad outcome.
Right.
People may feel like this is not the right treatment anymore. We need to stop it. So we need to choose the right patient, provide the right medical treatment, so we get the outcome that is good, low complication rate, so we increase confidence in this medical treatment.
Definitely. So we have a question here about a 2 centimeter solid nodule. Molecular test was negative. Would this nodule qualify for RFA?
So this is based on the research of genetic testing and evaluation of indeterminate thyroid nodule. The research indicates, and there's different platform for evaluation of genetic testing, but all of them come into the same concept, that when you have indeterminate thyroid nodule and you do genetic testing, the likelihood of cancer go down again to 3%. So we are down again to a similar of result of benign cytology. In those situations, what I do in my practice is if I have one benign, one indeterminate with negative genetic testing, I feel comfortable this is a nodule that really have low likelihood of malignancy, especially if on ultrasound, the probability of cancer is low. The nodule does not look suspicious. It's a mixed cystic solid without characteristic that make us worry about. It doesn't look cancer. And in that situation, yes, those patients will be a candidate for thermal ablation if they're causing them symptoms, causing them discomfort, causing them a problem that need to be solved. At the end of the day, not every nodule, because I have it, I need to ablate it.
Right.
It needs to be something that you need to treat for a reason. It needs to be something to be done to help you feel better. Just to ablate things because we see it, then that will be like extremely hard and also may not be useful. Many patients have thyroid nodule. The estimate in average in population, if you use an ultrasound, 50% of women at age of 50 will have thyroid nodule. And that's something need to be calculated. Not everything we see need to be treated. What is the problem? Is it causing an issue? And sometimes just observing is the right answer.
That's right. That's right. Yeah. In my particular case, I have a small thyroid nodule that I can't see or feel as far as symptoms go. And so my doctor and I agreed we don't need to do anything about that nodule. We're just going to let it be and watch it. What size of a nodule would potentially need multiple RFA treatment sessions?
There is no specific size that you can say for sure it will need multiple sessions or not. But generally, the general rule of thumb, if you are reaching 20 cc in volume, those nodules may need more than one treatment. You cannot say, oh, this nodule will need more than one treatment for sure, because basically you do not really know how it's going to respond. I have patients with nodule 40 cc, 50 cc, and you do one treatment and they go down to 5 cc or 7 cc. And the patient is not symptomatic, they're feeling fine. I'm not really doing anything additional. Just because I say that may need some treatment, that means I will need to do treatment. I have some patient, the nodule showing 30%, 50%, they are larger nodule, and the patient say, I feel good. I do not have any symptoms. I don't see it. I'm not bothered. That doesn't mean I need to repeat treatment. But if the goal, and we're trying to put the goal as I want to hit less than 10 cc, I want to get to a certain number as a goal, then yeah, you can argue the larger the nodule in average, if you have larger than 20 cc and you shrink them by 50%, it may take you more than one session to achieve that volume less than cc. But the goal needs to be defined. Seeing a nodule large, yes, you may need more than one treatment, but we're only going to know. It all depends on how you feel and how your nodule respond after treatment. But if you want to use a rule of thumb, most of the time larger than 20 cc may need more than one treatment.
And if a patient doesn't know the volume of their nodule, I just want to let everyone watching know that the ATA website actually does have a calculator where you can plug in the dimensions of your nodule and it will calculate the volume. And so that would give you, say you know the nodule's dimensions, but you don't know the volume. That would give you a better understanding of that. And also, I would just like to add the location matters as well, because if a nodule is very low in the neck, where maybe part of it is occluded by the collarbone, which was my situation, you can't see what's behind the collarbone on ultrasound. And so that part will have to be addressed after the top part is treated and moves up out of the way.
So this is bringing a very interesting point that I try to explain to everyone. When physicians try to measure a volume of a nodule, with the current way we use it, now there's new technology that may alter the way we measure the volume of the nodule, but currently we use 3 dimension to estimate the nodule, as the nodule is an egg shape or it's a fixed shape. They really do not have a uniform shape.
Right.
They can look like really different in different patients. And most of the time when physicians start measuring nodule larger than 25 cc, larger than 30 cc, there's a component of estimate of the size.
Right.
Because the nodule may not fit in the same size of the probe. Part of it may become deeper in the neck. And when we see those situations, we need to keep that in the back of our mind, that there is a component of estimate and it may not be exactly the same size. And I've seen some patients where the nodule we estimate 70 cc and the patient come back and the nodule shrunk to 40 cc and it's still large. The patient say, I feel fantastic, but you're already seeing it's still large, but it may have shrunk even more than what I am expecting. It's shrunk more than what I calculated, and what I calculated because I have measurement limited based on the probe I have.
That's a good point, because we do have some patients who say, oh, I'm disappointed my nodule didn't shrink more. I think that's a good thing to keep in mind, is that maybe it's just we're doing the best we can to measure and quantify things on ultrasound. But I think the point you're making that's so important is, what are your symptoms? How are you feeling? Have you improved? And that's the goal, is to make symptom improvement get better and also cosmetic improvement as well. So this next question is about 3 indeterminate thyroid nodules. The patient wants to know, if they have RFA, will they avoid the chance of them becoming cancerous?
If the question is asking, will RFA treatment prevent thyroid cancer from happening, that could be a valid point. Because if you have a nodule and you have a tumor or growth, and you completely destroy that tumor and you have no residual tissue of it, yes, you eliminated the risk of possibility of something happening. If the question is, will RFA make the nodule or become cancerous, or after RFA the nodule will become cancerous, there is data there that looked at thermal ablation and change of the nodule, and it does not alter the cytopathology or the way the nodule look after the thermal ablation. Will it prevent it from happening if you completely eliminate it? Yes. But if it's already benign, it's most likely going to stay benign until long-term data prove the otherwise. And if it is malignant, it's most likely going to stay malignant. That can happen. You're going to miss thyroid cancer when you are treating with thermal ablation benign nodule, because there's a possibility of that happening.
So the next question is a patient who had papillary thyroid cancer on one side. They had that side removed, and now they have a lump on the other side that is 1 centimeter. They want to know if it can be biopsied safely, and if it is cancer, will there be a risk of it spreading?
I'm going to try to answer this question on the way I understood it.
Okay.
So is it safe to biopsy a nodule that is 1 centimeter? Yes, generally it's very safe to biopsy a nodule is 1 centimeter. Will it spread because of the biopsy? Generally, the accepted evidence that fine needle aspiration does not cause the spread of the cancer outside the thyroid gland. You may have what we call a seeding of the tumor on the needle tract, but the frequency of that happening is around 0.1 to 0.3% in a nodule when it's malignant. So if you want to think about that, you have 100 patients who have nodule, 5 of them may have cancer, and then you need to have from those 5, only 0.1 to 0.3 may have seeding in that a fine needle aspiration. So the likelihood of that happening is extremely rare. In simplified way, I may spend all my whole career doing biopsies and may see one case.
Wow.
So that means 40 years, I may see one person. And if that's a physician who do biopsies, more than 50 biopsy a year. So in that situation, most of clinicians may not even see it in real life during their career. So that's how infrequent it is. And because not doing the fine needle aspiration may not give you the answer about how to manage this nodule, and you may end up with more surgery, the benefit of performing fine needle aspiration outweighs the benefit of concern related with the fine needle aspiration. But we cannot say it does not happen. It does happen, but it's extremely, extremely rare. Generally, the data indicate that patients who have aggressive tumor are the one maybe they will have the seeding after the fine needle aspiration. So those are the one who will need really the surgical intervention. So you want to know.
Right.
You need to, so you'll be able to help them. So I personally think fine needle aspiration is safe.
And what about RFA for this particular situation? They started off with a surgery and now they have this 1 centimeter papillary. If it is papillary thyroid cancer, would they be able to have RFA on that?
That it depends on the location. It depends on the nodule itself. It depends on the genetic profile. It depends on evidence if there's a cancer spread already to lymph node. There's data there indicate that when you diagnose thyroid cancer, by the time of diagnosis, 50% of people already have lymph node involvement. If you have one cancer on one side and now we have cancer on the other side, this is a multifocal disease. This will behave a little bit different than unifocal disease. So you need to calculate all those risk and benefit and decide based on patient preference, physician availability who will be able to perform the thermal ablation safely and completely, and combine all that to make that final decision. So there's going to be multiple factors to decide that. But in this situation, it's multifocality. And then you need to ask yourself, is there any research study now available in the US that do that? All of them exclude multifocality from their clinical trials.
Okay.
So that's an important thing to keep in the back of our mind.
I think this would be a situation where if I were considering RFA, I would want to maybe have molecular testing on that nodule at the time of biopsy.
Absolutely. The concern about it is really the insurance coverage.
Right.
But if you bypass that, let's kind of ignore that concept, insurance coverage. It will be very helpful too. If you have a nodule that have a low risk mutation, then you are estimating this is going to be a low risk recurrence thyroid cancer. If you have a nodule that have mutation that estimate the risk of recurrence 30 to 50%, you may want to be a little bit more aggressive about that nodule compared to the first one. So yeah, genetic testing can provide information, provide guidance. It's still in the early stages. I cannot say this is the standard of care in the US.
Right.
It's early stages, but it's very promising.
Well, and you mentioned insurance. What do you think about insurance coverage for RFA?
So we are expecting, hopefully, in the 2025 that we're going to have a code by Medicare. I was recently involved with survey through the Endocrine Society requesting information about thermal ablation and submitting to the Medicare to be able to have a code hopefully by the middle of next year. It's going to be reviewed, people work on it. Possibly it's going to be available in clinical practice in 2025.
Very exciting. Very, very exciting. This patient asks, can RFA be performed on multiple large nodules with a suppressed TSH but a normal T3 and T4?
Yes, here you need to kind of, again, define what you're trying to do. If you have multiple nodules based on their size, based on the reason why I'm considering thermal ablation, if we're talking about compressive symptoms, you may want just to target the largest nodule if the other two are benign and they're not causing issue. If you are trying to treat toxicity, the oversecretion of thyroid hormone, you want to do that evaluation. You want to screen for Graves' disease. You want to do the thyroid uptake and scan. You want to show, is it all of them are overactive? Is it one of them that is overactive and I'm trying to treat? So really the answer for that question, it depends. What is my goal? If the goal is I just want to zap the three of them, sure, everyone can zap all the nodule, but the goal is always what I'm trying to fix. And if we're talking about toxicity, then you need to try to evaluate, is it one or multiple? If you have a single nodule that is small, your success rate is higher. If you have multiple nodule and they are large, your success rate may not be as high, but it does not mean it will not work. It may need more than one treatment.
Right.
I do have a couple of cases of patients have bilateral thyroid nodule that are toxic, and some of them require 2 treatments, some require 3 treatments, but we usually achieve normalization in most of those patients. And that's something that need to be planned, understood, because there is a repetitive treatment here, and you want to have patients who feel this is the best approach for them. Another option is always available other than thermal ablation.
This next one is about biopsy result called FLUS. Can you tell me what that is exactly? I can't remember.
So follicular lesion of undetermined significance is a way of describing cytology. To simplify it, when we are looking at cells under the microscope, we may have either sufficient or non-sufficient. If it's not sufficient, we call it non-diagnostic.
Okay.
If they are sufficient, then you can divide them into groups, and based on how they look under the microscope, the more they look completely normal, you're going to call them benign. The more characteristic that suggests they are cancer, we're just going to go and call them cancer. And then you can see changes that does not fit exactly with malignancy, but it doesn't look completely benign. And it depends on the number of those changes. You divide it in different groups, and you give them, based on those changes, estimated risk of malignancy based on the research. So when you get this type of result, when we look back historically, we look at those outcomes when they remove them with surgery, and we find, hey, when we saw this and we took the nodule out, we found the likelihood of cancer is to be this. And that's how really we come with this estimation. So FLUS is one of those where you have an estimated risk of malignancy of 10 to 30%. This is kind of called category 3. In those situations, that's where genetic testing come in. If you have a negative genetic testing, the estimated risk of malignancy go down to closer to 3% based on the platform. And in those situations, you can say to the patient, if the nodule does not look suspicious, if it looks not worrisome on the ultrasound, low likelihood for malignancy, came back indeterminate because maybe there's an inflammation, maybe there is some recent bleeding, alteration in the tissue that cause it to look a little bit not uniform the way we like to see. Then you're going to say, hey, it doesn't look normal, benign, 100% on cytology. We're going to call it FLUS, a little bit concerning. And then that genetic testing add in and help you sort those out. In general, my clinical practice, I notice almost half of those patients will have negative genetic testing and they will avoid surgery, especially if it's not causing them symptoms. So that's the concept when we talk about FLUS. And there's other description, follicular neoplasm, suspicious for papillary thyroid cancer, and then papillary thyroid cancer. There are different categories describing different likelihood of malignancy based on the way they look under the microscope.
And then after a patient undergoes RFA, how does the body actually eliminate the thyroid nodule?
The way I describe it to people, think about when you have a wound, when you have a bruise, your immune system, your mechanism of healing will start working. You have immune cells, white blood cells, will immigrate and go to the area where the damage is, and they will try to reabsorb that dead tissue because you are destroying that tissue completely. And then your body will gradually heal it. That's why most people in 2 weeks to 4 weeks after the thermal ablation will start noticing a difference because that reabsorption, that healing process happens. It's not really different than if you think about how long it takes for a bruise to go away. It's just kind of very similar.
Yeah, and one confusion we do notice from time to time, patients will not realize that it does take a little while for the nodules to go away. It's not an immediate reduction in size. So I like the example you gave there of the bruise. It does take your body a little bit of time for it to process that.
And it takes time because you're not getting a complete death immediately for all cells. So remember thermal ablation, when you're delivering that electrical and heat, you have a diffusion of heat, and some areas receive heat less than other areas. It may take them more time to die, and that death may be programmed or gradual, so it may not happen immediately. So some things take a little bit longer. When the tissue is completely destroyed, that's where the inflammation will start. But when you start a process of irreversible death, So there's something we call programmed cell death.
Mhm.
It can happen gradually, and it may take few days or longer before the cell die, and then you're gonna see that also get reabsorbed. So it's a process,
Mhm.
but most of the time, most people really notice a difference 2 weeks to 4 weeks.
Mhm.
But the volume reduction reaches its max around a 6 months.
Mhm.
So you start seeing the volume reduction around the 6 weeks to 3 months. Most of it happened there, but it continued to shrink up to 6 months. And there's data that some nodule continue to shrink up to 5 years.
Mhm.
So remember, all this is a long process.
Right.
Most of it happened early, but it may continue to happen gradually over time.
Mhm. What is the actual cause of thyroid nodules? This is a question I get all the time.
It's hard to pinpoint.
Yeah.
It's hard to say there's one factor.
Mhm.
Everything really in life is a multifactorial. There's
Right.
so many things that kind of interact together. So we do know that tissue have tendency to be overactive. It does have the tendency to form nodules. So glands have tendency to form nodule more than bone. Bone does not form as nodule as much. It's less active. It
Mhm.
does not make hormone constantly. So it's the nature of the tissue. We think there's a combination of genetic alteration of DNA, TSH receptor mutation, a protein that drive course of the cell changing inside the tissue, and then it drives cell growth. We have factor related to environmental iodine deficiency. We have well-known documented information about if you live in a low iodine state, you're going to have a higher risk of forming thyroid nodule. And this could be a compensatory mechanism. When you have low iodine state, you may have a higher risk of becoming hypothyroid, and your body trying to compensate for the deficiency
Mhm.
by working harder and forming those nodules to secrete more.
Mhm.
And then with that, we also know age is a factor.
Right.
And that's just a factor of we live longer. These processes can happen more frequently, and
Mhm.
if they can happen more frequently, the chances increase.
Right.
So those factors add up together, but we can't say one single factor is the reason. It's most likely a combination of all, and I think they add up together to we see that high prevalence in women, especially.
Mhm.
We see 20% will have nodule at age 20, and almost
Yeah.
80% of women, if you use an ultrasound, will have a nodule at age 80. So it's
Yeah.
quite prevalent.
Yeah, I've heard the statistic 40% of 40-year-olds, 50% of 50-year-olds, 60% of 60-year-olds. Your percentage of risk goes up as you get older. And unfortunately, that's just how it is. So, okay, this next question, the patient is asking if RFA is available in the Philippines. And the last that I heard is physicians in the Philippines that are pursuing training in that are in the process of being trained. This patient has a right thyroid lobe mass that is 5 centimeters and 5 complex nodules on the other side. And they want to know if this is a possibility for treatment with RFA.
So they do have a large nodule, 5 centimeter on one side, and multiple nodule on the other side.
Yes.
So again, it will go back to the evaluation and the reason. Is this a benign nodule? Is it malignant? Is it
Right.
suspicious on ultrasound? So it depends really on the workup. You will be able to decide, does this patient fit in treatment with thermal ablation? I had once, I'm just going to give an example, patient who had a nodule, when biopsy came back benign. At that time, it was recommended for the patient to consider surgical intervention. The patient did not feel surgery is the right answer. They came to evaluate, and it took some time to evaluate. But when you look with the ultrasound, the first impression I had, this is not a benign nodule. This is malignancy. There is no more workup. It already looks suspicious enough that needs to be removed. When you look with the ultrasound on a nodule, you cannot see the border, where it starts, where it ends. It doesn't have well-defined border. Then not every patient will be qualified. They need to have a workup. It's not just a size.
Right.
It's not just because I have symptoms. You need to choose the right treatment. You need to make sure you stay healthy, and the right choice is important to get that outcome.
The next question is asking about papillary thyroid cancer less than 1.5 centimeters. What is the outcome for most patients who have RFA in this situation? How successful is it?
I can talk about 1.5 centimeter. I do not really have data. The studies, as I mentioned, from South Korea was 1 centimeter, and they have 5 years follow. Currently, there's clinical trial, as I mentioned, for thermal ablation. He may want to consider one of those clinical trial if he wants to be part of that. I do know that this is a tempting for physician to consider treatment, but again, you want someone who's experienced, who
Exactly.
had the skill, and who is monitoring you for long-term follow-up.
Right.
You want a physician to be involved in your care for long term, because it's not just I ablated this. We need to evaluate it for a spreading to make sure there's no evidence of the cancer coming back. We need to make sure this nodule, that 1.5 centimeter, is completely destroyed. And that physician need to have the skill to understand and know where it's located. Does it cause permanent damage? Do we have other complications that can emerge from that? And did I do my workup to make sure it's not already spread outside the thyroid? And this is advanced disease. This is really hard to answer directly, but I think if the person is interested, they should seek out one of the clinical trials, because then you're going to be able to get more answer about the long-term follow-up.
And I think you made a really good point about this patient, if they were to undergo RFA, will need to be constantly going for their follow-ups. It's very important to maintain that follow-up and see how things are changing over time. The next person says their surgeon told them that RFA is not considered for thyroid cancers because the thyroid cancer goes within the thyroid gland and spreads after RFA. Is this true?
I think we need to divide this into two different concepts.
Okay.
Is thermal ablation considered for thyroid cancer? We already mentioned there are studies about that. There's a research in the US working on cancer less than 2 centimeters. The other concept is if I have a cancer of 4 centimeters and I do thermal ablation and I destroy 90%, but there's some areas where the vascular flow is not completely destroyed, it's compromised, and there's cancer cells in that area. Is it theoretically possible this cancer may spread? Theoretically, yes, it's possible. That's why we do not like to do big nodules.
Right.
When we try to ablate, again, we mentioned, I want to make sure I'm burning the tumor and I'm burning a little bit of healthy tissue surrounding it, trying to make sure everything been eliminated. So yes, from that concept, if we are worried about theoretical risk of cancer spreading, it's possible if you are treating large tumor and you're burning 70%, 80%, there's 20% cancer in the neck. Yeah, that's a possibility. That's why choosing the right patient, choosing the correct patient for the medical treatment is essential to get a good outcome. The last thing we want, I avoided surgery. Now I have metastatic disease to the lung. I have metastatic disease to the bone. We need the right treatment.
Right.
So in that concept, the physician is correct, maybe not correct saying there is no role for it for thyroid cancer, because there is a role for it for microscopic cancer, for cancer that is well defined, an imaging study that we also can consider for patients who are in active surveillance for thyroid cancer. There's many patients now, they choose to, when the cancer is small without any evidence of a spread of the disease, to actively surveil that. So really choosing the right patient is important. We cannot generalize. We cannot say because this is a possibility, then this treatment should not be considered. All medical treatment have their pitfalls. We need just to choose the right medical treatment for the right patient.
This patient says, I've heard that people who are pregnant or have pacemakers are not candidates for RFA. Why is this the case?
So I'm going to divide this into two different groups. So the point of the pacemaker, you are delivering electrical current. An electrical current, if you have a monopolar, the electrical current going through the body and to the grounding pads. If you have a pacemaker which has an electrical component, things can be fried if electricity go through. You're going to have a problem. So that's the point why we are worried about the pacemaker. In that situation, monopolar antenna may not be a choice. There's some things that physician can do, and our colleague and ourselves. We alter the way where the grounding pad is. We may communicate and talk to the physician who's managing the pacemaker and find a plan that we can still do the procedure safely if we wanted to go with monopolar. But
before you move on, can we just really quickly tell the people watching what monopolar means about with the antenna?
So the concept of monopolar and bipolar is on the antenna. When you say monopolar, you have one side. Think about two poles of the battery, of two poles of electricity, negative and positive. Monopolar, you have one side. And then you have the grounding pads where the electrical current going to go through from one area to the other. When you have a bipolar, it's on the tip of the antenna. The whole circuit is going around that tip. So there's no electrical current going beyond.
A bipolar antenna, the patient would not need those grounding pads on the leg.
Correct.
Okay.
So we done, I'm not sure, but I think we done the first case of bipolar antenna, and gentleman was almost 3 months ago. Interestingly, I'm going to be seeing him soon to see the outcome. Thermal ablation went very well, very nicely, but that's kind of the concept. So you can do either still use monopolar, but with adjustment of the setting of how you want to treat, or you can consider the bipolar antenna. Most of physicians try to avoid being in that situation because, again, the whole concept do not do harm is very essential in practicing medicine.
Of course.
Now, pregnant is a little bit different scenario. There's always a question is why I'm doing something during pregnancy. What's the reason why I need to do a treatment during pregnancy? Is it an emergency? Is it an urgency? Is it an elective? Is it something I can wait and do treatment after? In monopolar, the same concept apply because, again, we're talking about electrical current going throughout the body. That means it may affect also the fetus. There's not going to be a clinical trial of let's do monopolar and see if that have a risk on the fetus. That's not going to happen. That should not happen. In that situation, one can argue maybe a bipolar antenna theoretically is safe during pregnancy. But again, the questions stand the same. Why I need to do a medical treatment for a thyroid nodule during pregnancy. Example, we occasionally, for patients who have papillary thyroid cancer during pregnancy, we recommend, if we don't have any evidence of the cancer spread outside the thyroid, it's still maintained, it does not look like it's growing rapidly during pregnancy, we recommend monitoring and waiting and do the surgical intervention after delivery. There's always need to be a good reason why we are deciding to do a medical treatment throughout, but the concept why my monopolar is contraindicated because we do not have any data about safety during pregnancy.
This next question is a patient has had a biopsy 6 years ago, but after molecular testing, it was inconclusive. The patient opted to watch through ultrasound yearly. No changes in the nodule, and it was downgraded. Would this be a scenario where RFA might be considered?
I'm not sure about what they meant by downgraded. If you have a nodule suspicious on ultrasound, as I mentioned, and you have benign cytology, you are still worried about that nodule. If they are referring that your nodule had a suspicious for malignancy, that means the risk of cancer is around 70 to 90%. Most genetic testing does not usually make that low likelihood significant to be low suspicious or not worsen. I think the available platform, some of them even do not do genetic testing for the suspicious of papillary thyroid cancer, if this is what we are referring to when they're saying suspicious. I'm just trying to kind of use the word they use. So seeing a nodule not growing, it does not mean it's not bad. We already know from data for the active surveillance of thyroid cancer, most of thyroid cancer is slow growing. It may not change drastically, and it may stay stable over years. Problem is you do not really know when it's going to be back. Is it going to be in a week, in 2 weeks, in 3 weeks? But when you monitor microscopic papillary thyroid cancer, most of those nodules stay stable over time. So not seeing a change, not seeing a becoming worse on the imaging study for a few years does not make the nodule less worsen or more worsen. It does not alter the data you had. You had a suspicious thyroid nodule, you had suspicious finding. Your result is inconclusive. This is a nodule that you still don't really know what type of nodule you are dealing with. Now, one can play the devil advocate here and say, I have a 7 millimeter nodule or small nodule, and it came back suspicious for PTC, and the genetic testing came back, estimated risk is maybe lower. Maybe I have a role for RFA. Yes, that's where the researchers, that's where the clinical trial is going on right now and trying to say, yeah, there may be a role for this there. But if, let's say, I'm not sure, did they mention the size on this nodule?
I don't think so.
But let's say this is a 3 centimeter or 4 centimeter nodule. It's suspicious. And then you need to be careful.
Right.
You need to be careful about what you are trying to treat. But let's say it is thyroid cancer. It's the worst case scenario. Then you can argue maybe microscopic. I may fit in clinical trial if, again, I fit a specific criteria for a clinical trial. And if I have a nodule that is like 4 centimeter or 5 centimeter, maybe you are not the best candidate for thermal ablation because we're not sure exactly what's your risk. We don't downgrade if nodules are stable because we do know thyroid cancer may not change and become larger because it's thyroid cancer. It may take years to change.
We have a patient asking about how they've had several chest CT scans over the years. Now they have discovered thyroid nodules. Why have these not been discovered sooner? And I'm thinking this is probably a situation where the thyroid nodules hadn't developed until recently. What do you think about that, Dr. Aljammal?
It's a little bit hard to say. Remember when a physician do imaging study, they may not include a specific part of the neck for evaluation. Generally, the thyroid is part of the CT scan of the neck. You can see it, but it's not
Okay.
always going to be there. And then it depends on what type of nodule we're talking about. Generally, nodules take years to evolve. They don't happen overnight, but they do. You can have sometimes a 5 millimeter or a 7 millimeter nodule, and suddenly you can have an acute bleed in it, and it changed from few millimeter to 3 centimeter. That can happen very shortly. That's not bad. It just a bleed happened in the nodule, and you did not see it because it's 5 millimeter or 7 millimeter. To understand CT scan, they have different what we call them cuts, and it's the difference between one area and the other. Some of them we call high resolution, and the difference is a couple of millimeters. Some of them are 5 millimeter. If you have a nodule that it measure 7 millimeter, you're not going to be able to see it.
Right.
And we do know CT scan is not as sensitive as ultrasound to pick up thyroid nodules.
Right.
So a lot of time there may be small things that they are not even notable on the CT scan because the tool of evaluation is limited. So there's many factors why you may not have seen something, and now I do see something. But generally, thyroid nodules do not evolve suddenly and very fast. Usually, they happen gradually over years. Not always. I'm not going to say. When I say generally, it means most of the time. If something really truly is a growth and a thyroid nodule that happened over a short period of time, that usually is very worrisome. That's very worrisome in general. But it's not the common thing. The common thing is you do have a nodule for years, and it's been gradually changing and happening and evolving. Because that's, as I mentioned, 60% of nodules, when you keep an eye on them, they stay stable. They don't really change. 10 to 15% grow. So why they did not see it? Limitation of imaging study. Did that area was involved before when they did the previous imaging study? Was it high resolution, low resolution? What was the method of evaluation? Was it a cystic nodule and it just expanded and now they do see it? So there's going to be a lot of reason to answer that. And there's maybe other reason that I did not touch base on, but those are in general the things that come to my mind.
And ultimately, the best imaging for thyroid nodules is going to be ultrasound, not MRI or CT, correct?
Not always.
Okay.
If, again, we go back, it's ultrasound is very, very sensitive to pick up things superficial. So it can see the thyroid, it can evaluate thyroid. But when you go substernal and deep in the neck, you're not doing a good job with the ultrasound because the bone will block your visual. You're not going to be able to see. Ultrasound is great, as I mentioned, for things superficial. Sometimes goiter are large. They can go behind the trachea and you're not going to see them clearly. So in a way, yes, the most sensitive first tool for evaluation is an ultrasound, but it can be complemented by additional imaging study with CT scan or other type of imaging study based on the scenario.
Okay.
Sometimes, which is very hard to see tracheal deviation and evaluate with an ultrasound, a CT scan may have a better capability to show you there is a push on the trachea. So there is really different method of evaluation. You need to use the right one for the right situation. But in general, you're right. The most sensitive, the first step in evaluation of thyroid nodule in general is going to be the ultrasound. Most of the time, it will give you most of the information you need on your workup, but occasionally you supplement with other things. Like example, when we're dealing with micropapillary thyroid cancer, you want to do a CT scan, you want to do an enhanced CT scan to evaluate for lymphadenopathy. Ultrasound does not see things behind the thyroid clearly. So CT scan may be able to pinpoint and find things that you may have completely missed using just an ultrasound.
Okay. Thank you for clarifying that. I did not realize that about the lymphadenopathy. That's a hard word to say. Hydrodissection, can it adequately address the heat sink effect for nodules close to large arteries?
So a hydrodissection, what you're trying to do, you are trying to separate organ like the arteries or the vein or a possible course where you're expecting the recurrent laryngeal nerve or other nerve to be close to that area. Heat sink effect is basically when you are delivering heat, and because of the continuous blood flow, the injury related to heat is going down because it's getting cooled by lower temperature of the blood. So in a way, heat sink effect is kind of a protective to that area where you're trying to ablate. So if the question is, and I'm again here trying to understand the question based on their description, is this will help to achieve a better ablation? Yes, hydrodissection can create a buffer and make the physician be able to reach closer to the area that they're trying to ablate. But again, we need to go back. What's the point? If medical treatment goal is to reduce a volume and have less complication, I think hydrodissection will help in that situation. If I'm trying to treat a toxic nodule or my goal is completely eliminate that nodule, I think hydrodissection will help. If I'm trying to reduce a nodule that volume is like 40 or 50 cc, hydrodissection first initial treatment may not really alter as much the outcome because you are already dealing with a very large nodule and you need to see the first response before you decide is there going to be a second treatment or no additional treatment. So it has its role. It may help in achieving a better and complete ablation, but I cannot say hydrodissection is needed for every single nodule that need an ablation per se. But it has its role and it does really help kind of get a little bit closer to an area where you may be afraid if you did not have the hydrodissection. And we use it occasionally when we feel there's a need for it.
Okay, well, that brings us to the end of our questions. I would like to thank Dr. Aljammal for answering all of these wonderful questions from our community today. And thank you everyone who attended this webinar for being part of our community, Save Your Thyroid. And for anyone who is looking for more information about Save Your Thyroid, please visit our website, saveyourthyroid.org. If patients want to learn more about Dr. Aljammal or connect with him, you can visit thyroidclinicutah.com. Thank you so much, Dr. Aljammal, for joining us today. This has been very informative. Thanks so much for listening. Please share this content and help others. If you need resources, testimonials, and support, please join our patient community, Save Your Thyroid. You can also find me on social media and Substack under the media handle, It's Me, Jen Again. Never forget to educate yourself and be your own advocate and save your thyroid.